stenosis in the cervical spine. The presentation, the most common presentation of a cervical disc herniation or cervical degenerative disc disease is actually not neck pain or numbness, tingling, or weakness. It's actually pain around their scapula. It's pain right here. You can just massage it for me, doc. It'll get better. I always tell them that I can massage it, but I'm much more expensive than most other places. Instead. But that's a common presenting symptom, pain around their scapula. And we try to treat these patients with conservative management, physical therapy, anti-inflammatory medications. And if that doesn't get any better, then we get an MRI scan of the cervical spine. But again, we try conservative management for at least 6 weeks before putting patients through an MRI with a cost and inconvenience. And again, I'm not sure how well you can see that back there, but here's your brain stem, and then the cord goes down through here. Here's a disc, this. And you can see the first two discs are pushing into the canal onto the at least the central cord. And if you get axial images, you can see if it's pushing in the neuroforamen as well or not. We get X-rays to look at their alignment. Now, if you look at the X-ray of this cervical spine, again, you can see how this height is normal. This is not. This is compressed down, bone forming in the front and in the back. So the only time we get early MRIs is if they are myelopathic, meaning if they report problems with their balance or dexterity, if they have physical exam findings that are consistent with myelopathy, their reflexes are hyper, you push on their patellar reflex and they kick you in the face. That's not normal. A lot of my patients are concerned that I can't get a reflex. Well, that doesn't concern me. Not getting a reflex is okay as long as it's symmetric. But if I go to tap your need for your reflexes, and you're kicking the ceiling, that could be abnormal. Those patients that are reporting weight loss, if there's any fever, chills, night sweats, then I get an MRI to look and see if there's anything bad going on. We also get electrodiagnostic studies. I gotta tell you, I don't use that very often unless there's some confusion into what is causing their pain. And to get an MRI and they have a disc herniation on the left side and their pain's on the right. It happens a lot with my work comp patients for some reason. But then I get an EMG to see if I'm missing something, or I'm going to get a CT mammogram to see if I'm missing something. I don't dismiss it just because it had a work injury. I still have to work it up, and electrodiagnostic studies can sometimes help. If they have degenerative changes at multiple levels or weakness in their biceps, which I know is a specific nerve root, then I'll have a friend of mine inject around that nerve root to see if they improve. Again, whiplash injuries can cause pain in your muscle, in your facet joints, and then it could be disc-mediated pain. In the acute phase, we use physical therapy, we use anti-inflammatory medication, we never use a cervical collar. We don't, unless there's instability, there's no need to stabilize them with a cervical collar. We actually encourage range of motion and strengthening. Non-steroidal anti-inflammatory medications, muscle relaxants, reassurance. And if that fails, my staff already knows what I'm going to do before I see the patient. If they've had physical therapy and anti-inflammatory medications and that didn't work, then I send them to a pain management specialist who will inject them in places that I think are generating the pain. When all that doesn't work, then I think, can I help them with surgery? And is the problem bad enough to require surgery? For neck pain, the cervical discogram can help localize the level. Now, with cervical radiculopathy, which is numbness, tingling, weakness in the arms as a result of compression of the nerve in the neck, it's much easier to figure that out because 80% of neurodeficits corresponding to the fending disc level, meaning if the disc herniation is at C5-6 on the right side and it's pushing on the C6 nerve, and it should have weakness or sensory deficit in C6 nerve distribution. But again, there's many other things can cause the types of pain that you get from a disc herniation. Peripheral nerve entrapment, rotator cuff pathology. One of my partners, Dr. Burrow, who's a very smart guy, was trained with Dr. Andrews down in Alabama. He's smart guy, but we're sending patients back and forth with each other all the time because, is it the rotator cuff or is it the neck? I don't know. They have pathology on both MRIs, so now let's try to figure it out. And one thing that helps us is first we send them to physical therapy and we hope it goes away, and so we don't have to figure it out. But if it doesn't go away, then we get help from pain management specialists who will help us by injecting either in the shoulder or in the neck and see what helps. And the non-operative management, again, is physical therapy, traction, steroid injections, non-steroidal anti-inflammatory medications. All these non-operative treatments are essentially the same for the lumbar and the cervical spine. The non-operative treatment of disc degeneration, again, is the same. Traction, steroid injections. Now, if you ask me, I'd say surgery always works. And if you ask pain managers, I'd say our injections always work. But that's not true. They don't always work. What I tell, and I send patients to injections all the time. I send 5 patients out of every clinic to get an injection. And the patients always ask me, well, am I definitely going to be better with this injection? And my answer is, no. Really not. What we're trying to do is we're trying to make it better to save you from having to do a risky operation. And a lot of these patients do get better. Now, what's the percentage? I don't know. I can't really say. But if they have progressive deficits, progressive neurologic deficits, then we consider surgery. If the pain is not improving with the injections, then we consider surgery. The surgical success rate with cervical fusions is 85 to 90%. I think it's higher. But we still try not to treatment before we recommend surgery. Some of, this is real quickly, anterior versus posterior. The more common procedure is an anterior cervical discectomy and fusion. It's less risky. The results are better. But you're fusing a segment, and these patients will have adjacent level degeneration. The level above or the level below can break down in 30% of patients at 10 years. Now, it's not always symptomatic, but you know you're doing it. And so in younger patients, if they have a lateral disc herniation, we consider going from the back. Again, just doing sort of a discectomy from the back in the cervical spine. Much less risky in the cervical spine, but we're sometimes forced to do it in very young patients. Someone in their 20s or early 30s, cervical fusion is not a good surgery for them. Now, cervical disc arthroplasty, it depends on who you read. We had a lot of papers published out of Texas Back Institute that said if you get a cervical disc replacement, you'll be able to fly. That's not true, right? I think the results from a cervical disc arthroplasty are at least as good as a cervical fusion and maybe a little bit better, but it's not what it is initially built up to be. That's all I have. I'm trying to go through this as fast as possible.
Anybody have a question for the doctor? Question?
What features